Thanks very much for inviting me here. I'm very happy to be here, and I really enjoyed the lively discussions we had this morning. And I look forward to your questions about this talk as well. So this talk is on inequality and unintended childbearing in the United States. And I'm focusing on two specific research questions. First, I'm asking how levels of unintended childbearing evolved over the second half of the 20th century in the United States. So this is a time period when there were pretty big expansions in access to contraception and abortion. So lots better ability of people to manage their reproduction, and also really big changes in women's economic opportunities. So change the sort of context for decision-making about having children. So looking at how those changes related to changes in unintended childbearing. And then my second question is how inequality in unintended childbearing evolved over the same time period. So how did differences, I'm going to look at education groups as the main axis of inequality. How did differences in the experiences of more and less educated women change over this time period? So I want to start with the definition of unintended childbearing. An unintended birth is a birth that happens at a time when a person before the pregnancy didn't want to have a child. It's typically measured in survey data with a retrospective question. So after a birth has taken place, someone's asked, well, how did you feel at the time you became pregnant? If they didn't want to have a child at all at that time, the birth is referred to as unwanted. If they wanted to have a child at some point, but they just wanted the child later than they had it, the birth is labeled as mistimed. And unintended is an umbrella category that includes those both unwanted and mistimed births. And I want to be clear here, these are births that are labeled as unintended. We don't label the children as unintended. People's feelings may change after they actually have a child, but this question is looking at before you became pregnant, did you think you wanted a child at that time? And there are some challenges with this measure. So partly there's this question of asking people to remember back to their feelings before they became pregnant when they may already be a parent. And there are also some challenges in that we know from talking to people that a lot of people have mixed feelings about childbearing. There may be some things that are attractive about becoming a parent, some things that are maybe a little bit worrying about becoming a parent. This question requires them to say either yes or no, I wanted a child at this time. So one of the challenges is that a lot of births that are labeled as unintended may really be more sort of ambivalent births or not deliberately planned births, but not necessarily avoided births. So there are some challenges here. It seems like this measure works pretty well empirically. It's correlated with a lot of outcomes that we're interested in. It's correlated with a lot of behaviors that we're interested in. So it seems to be a good enough measure, even if it's maybe not a perfect measure. So unintended births are usually studied as a social problem. You could say that just the fact of having a child when you weren't deliberately trying to have a child is a marker of constraints to autonomy or constraints to efficacy in carrying out intentions. Unintended childbearing is often used as an indicator of gaps in family planning services, so as a sort of measure of the healthcare services. And unintended births are associated with negative outcomes across a wide range of domains: physical health, mental health, relationships, family formation. For parents, for the children born from unintended births, for their siblings, and for sort of relationships between parents, parent-child relationships. So there's lots of reasons why we might want to reduce unintended childbearing. But unintended childbearing in the United States is very common. About 1 in 3 births in the US is labeled as unintended, according to that measure I just showed you. It's generally assumed that levels of unintended childbearing are higher in the US than in other wealthy countries. It turns out that the US is the only country where fertility surveys regularly measure unintended childbearing. So actually directly comparable data aren't readily available. And some recent evidence suggests that unintended childbearing is more common than we might have thought in other wealthy countries. Particularly even in countries with very low birth rates, people may not be having children at the time points when they want to have children. So it's not clear the extent, how much this is really a US specific problem or how much this is a more general. Although unintended births are common sort of across the whole population in the US, they're more common among disadvantaged women across lots of different axes of disadvantage. So I said, I'm going to be talking mostly about education today. Unintended births are more common among less educated women. They're more common among women with lower income levels, among women with lower household wealth levels. They're more common among women in minoritized racial and ethnic groups in the United States. And so because of this concentration among disadvantaged women and because of the negative outcomes associated with unintended childbearing contributes to widening inequality in the United States, to the intergenerational transmission of inequality and to inequality in the family environments that children are. So then why is unintended childbearing so common, particularly in the United States, where you would think that contraception and abortion are widely available? So one answer to that question is that although in theory contraception and abortion are widely available, in practice there are a lot of gaps in access. That's related to financial costs of contraception and abortion. That's related to practical challenges to access, particularly for abortion, where there's a lot of geographic inequality in abortion care access. So a lot of people have to travel for abortion. But also for contraception, a lot of the most effective contraceptive methods are only available by prescription in the United States. And so there's differential access depending on healthcare coverage. There are also levels, people might not be satisfied with available methods of contraception. There's sort of limited set of methods. They're annoying to use. They have side effects. So that may limit access to contraception. And then there are social costs related to negotiating with partners around contraception or related to social stigma. And it's important to note that these gaps in access are not evenly distributed across the population. So they may contribute to explaining both overall levels of unintended childbearing and inequality in unintended childbearing. So this first set of explanations is about sort of ability to manage reproduction. The second set of explanations is more, you might say, around motivation to manage reproduction. So the idea that a lot of people have mixed feelings about having children, and if you have mixed feelings, you may be less likely to use the most effective methods to manage reproduction. And again, this sort of uncertainty or ambivalence about having children is likely not evenly distributed across the population. It might be related to external circumstances, so people who in theory would like to have a child but feel like they don't have the financial resources they need in order to have children. And it might also be related to perceived alternatives to childbearing. So in particular for women, there's some evidence that women who have access to kind of more attractive opportunities outside of the family, so better jobs, more education, ways of having fulfilling lives that aren't related to parenthood, that might change the way women think about having children and might change their motivation to use effective methods of contraception. So again, these contribute to inequality as well as overall levels of unintended childbearing. So to kind of think about how these different factors might interact in producing unintended childbearing in the United States, I want to look at changes over time in unintended childbearing as this broader social context has changed. The social context around access to contraception and abortion, and the social context around economic conditions, and particularly economic opportunities for women. So over the course of the 20th century, as I said, mostly increased access to contraception and mostly sort of improved economic opportunities for women. I got interested in this topic because I was reading some demographic research from the 1960s, and scholars writing in the 1960s really thought that the introduction of the contraceptive pill was going to like totally change unintended childbearing, was going to reduce levels of unintended childbearing to zero. It turns out that didn't happen, but there were a lot of big changes in the 20th century that sort of transformed the ways that people could think about managing their families and make decisions about having children. So in 1960, the contraceptive pill was approved for use. There were initially a lot of restrictions among who could access the pill. In 1965, there was a Supreme Court case that ruled that married women had the right to use contraception. This was expanded to unmarried women in 1972. In 1970, the federal government established a program, the Title X Clinic Program, which was designed to make contraceptive services more available to low-income women. So this was providing low-cost contraception and low-cost contraceptive counseling. In 1973, a Supreme Court case legalized abortion in the United States. Abortion is a story of sort of changing access over time, where 1973 saw a big opening of access, and then in the 1980s of state laws started restricting those accesses. But there was this big sort of turning point in 1973. And then in the early 1990s, the development or the introduction of new contraceptive technologies that were longer lasting and enabled people to prevent pregnancy with less sort of continued action on the part of the user. So in 1990, the approval of the contraceptive implant, which lasts for up to 5 years without having to do anything about it. And in 1992, the introduction of the injectable contraception, which lasts for sort of 3 to 6 months of highly effective hormonal contraception. So that's the sort of changes in access for contraception and abortion. When we think about women's economic opportunities in the United States, we don't see so much these discrete milestones, but we do see a sort of gradual period of change. Vinny showed this morning change of stability in college degrees overall in the United States, but that was a period where there were big increases, especially earlier in the period for women in the attainment of four-year college degrees. Over the second half of the 20th century, there were big expansions of women's labor force participation, especially among married women and women with children who had the lowest levels of labor force participation in the early part of the century. Women began to enter into male-dominated fields. There were big growths in women's wages. So these are sort of gradual changes that were the most marked in the early part of the period. A lot of these changes, these expansions stalled in the 90s. So less change in women's economic context in the 1990s than there was earlier in the period. And a lot of these changes were really uneven across social class. So for example, the entry of women into male-dominated fields in the United States was much more common in sort of professional fields that required a college degree than in lower status manual labor. The growth in women's wages was much more marked among women with higher levels of education and in higher status professional jobs. And this is also a period, as some of our speakers this morning said, where there's overall expansions in economic inequality in the United States, experienced by both men and women. So return to these motivating questions. How did levels of unintended childbearing evolve over the second half of the 20th century in the United States? We would expect declines based both on expanding access to contraception and abortion and on growing economic opportunities for women. How did inequality in unintended childbearing evolve over the same time period? I think there the expectations are a little bit less clear. On the one hand, you might think that expanded access to contraception and abortion would be good for everybody. This is kind of the lifting all ships argument that we might expect convergence across more and less advantaged women. But on the other hand, the unequal expansion of economic opportunities might lead us to expect differences between more and less educated. So to address these questions, I'm going to use data from a big set of cross-sectional nationally representative surveys of women of reproductive age in the United States. These are the national fertility surveys and the national surveys of family growth. So ranging from 1965 up into 2013. And there's actually a couple more recent NSFGs too that I haven't yet added to this time series. All of these surveys collect complete birth histories, including both intended and unintended births, and use very similar measures of unintended births. And so I pooled data from these surveys to produce trends over time from 1960 into 2013. Most of what I'm going to show in this talk is descriptive figures, so just some very straightforward combined data. I've also estimated multivariable models. I'm not going to talk about those much, but they show results very similar to the descriptive figures. And I'm going to show figures for the whole population combined and then broken down for women with different education levels. So this is the basic result. I could stop here and give everybody chance to stretch and wake up a little bit after lunch. But so this figure shows the proportion of births that are reported as unintended, starting from 1960 and going up to the first decade of the 21st century. So you can see in the early part of this time period, let's see if I can work this. No, I can't. But in the early part of this time period, about half of all births were reported as unintended in 1960. That declines slightly over time to about a third of all births in the early part of the 21st century. And I have some indicators on here, there's sort of like big changes in contraceptive and abortion access. So the contraceptive pill in the 1960s, the Title X clinics and abortion legalization in the early 1970s, the introduction of long-acting contraceptive methods in the early 1990s. And what it looks like is that there's a pretty big decline in the 1960s, coinciding with increased access to the contraceptive pill, and then pretty much stabilization. No change in the level of unintended childbearing from about the late 1970s up until the present. There's a little bit of up and down, but we don't see continued declines as contraceptive access continues to improve. And in particular, we don't see responses to, for example, the legalization of abortion during the 1970s, which is, again, not what people expected in the 1960s. So what happens if we look at differences in trends across education level for women? This figure shows 4 education groups with less than secondary education. That's the lowest education level at the top. This is a small group, and it's an increasingly selected group in the United States as education levels are expanding. People who don't graduate from high school are increasingly distinctive. So I want to focus on the 3 kind of low to middle levels of education. So that secondary degree, a high school degree with the dotted line on top. The dashed line is people with some post-secondary education, but not a 4-year college degree. So this could be people who started college and dropped out, or this could be people with a 2-year degree. And then the solid line at the bottom is women with a 4-year college degree or more. So you can see it throughout the whole period, women with the lowest levels of education have the highest proportions of births reported as unintended. And throughout the period of study, the most educated women are the least likely to report births as unintended. But the other striking thing about this figure is for the most educated women, the levels of unintended childbearing continue to decline pretty steadily throughout this whole period. So we do see a big change in the 1970s and 80s and 90s for the most educated women. It's the women with sort of middle and lower levels of education who see this kind of stagnation in unintended childbearing, and even an increase in the proportion of births that are unintended among women with secondary education. So the sort of combined effect of these different patterns of change is a big increase in education differences by the end of the period. So those lines are pretty close together in 1960. They're pretty far apart by the early part of the 21st century. And I am not going to talk about the multivariable models again, except to say that this holds up when you account for changes in population composition, changes in family formation in the United States. The multivariable results look very similar to the descriptive results. So I think my takeaway from this is that improved access to contraception and abortion doesn't really seem to be the main driver, especially not after this initial big response, the introduction of the contraceptive pill in the 1960s. So we do see an initial decline, but those declines were much larger and more sustained for the most educated women than for women with lower levels of education. So what do we think about then in terms of what is driving these large and widening education differences in unintended childbearing in the United States? And I think one way to think about that is to sort of not focus on unintended births so much, but to think about who is able to have intended births. So by definition, an unintended birth takes place in a context where you don't want to have a child. And if we look at qualitative data, we know what is a context in which people want to have children in the United States. People prefer to have children in stable partnerships, either marriage or a long-term romantic partnership. People want to be economically stable before they have children. They want to have stable housing, preferably in the United States. People say they want to own a home before they have a child. And the people who have access to these conditions are disproportionately in the United States the most advantaged people with the highest levels of education and the highest levels of income. And even if people with high levels of education don't currently have those things, they don't yet own a home, they aren't yet in a stable partnership, they're much more likely to feel that they will eventually reach those conditions, that those things are achievable. And so they're more likely both to have children in situations where they think are favorable to having children. And if they're in unfavorable situations, there's sort of more reason to postpone childbearing until they achieve those conditions. Whereas more disadvantaged people are less likely to be in these situations and are less likely to feel like these conditions are achievable, and so are less likely to sort of feel motivated to wait to have children until they've reached this kind of desired plateau. So I think this is well captured by an increasing body of research that comes from a reproductive justice framework. Reproductive justice is a framework that was developed by Black feminists in the United States in the 1990s. And they defined reproductive justice as the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. So this is a framework that talks about both preventing unintended childbearing and facilitating intended childbearing, of sort of thinking about all of the desires that people might have and giving people a capacity to reach all of those desires, not just the kind of negative desire of preventing unintended childbearing. So I will stop there and I will look forward to your questions and comments.